that's in there, much like what you see on here. There are also those that get it late, where essentially the arachnoid granulations are, just plugged up with the proteaceous gum from blood breakdown products, and these patients end up getting shunted. It depends on the tolerance for waiting it out. Those that want to get patients moved well, the ventriculostomy is still in there, and it's been a week, the shunt rates tend to be about 30%. And it's like, well, let's give it another week and so on. And if you wait out and through the second week, these shunt rates tend to now be about 15%. So he pays your money, he takes your chances. The other thing we always worry about early is theoretically, although I've certainly seen it happen in this theory, is that all this pressure from the ventricles and the pressure of the brain pressing on the aneurysm, and now we release it, and now the pressure inside the aneurysm, and that very unstable clot, now has a much higher gradient outside the aneurysm, and kaboom. And I used to believe it was theoretical until there was theoretical red stuff flowing all through the ventriculostomy. Yeah. So
Fortunately, it doesn't happen very often.
Well, I think we're careful now. Certainly I never opened the back pressure to anything less than about, at that point, about 20 millimeters of mercury. Why that number? Because somebody taught me. And therefore it's right.
Well, especially if you haven't gotten the blood pressure controlled yet. You're still down in the ER when you put the ventricular in, and you're still waiting for your cardiac drip.
I don't
want to
wait.
drop the transmural pressure.
I guess that's a question of how much, I'm going to go, how can I help you? Can I help Agnes?
Well, you put the ventricular in while they're looking for the cardiac.
The thing is, here, this has features of a little bit of everything. From the horn to dilated, diffuse blood everywhere. There's blood down into the fourth ventricle, diffuse swelling. I mean, this is actually from your patient. I pulled this one out. This is not some other ideal patient. I mean, this is just a classic. I don't know. I'm trying to think of something. But that's the dead chicken. What is this? It must be something. So this is a little bit of everything. This was not a subtle case. Briefly, I'm not going to go through what things we went through this morning. I look at that sort of as dealing with subarachnoid hemorrhage. I've shown you it's a biphasic illness. We've got to deal with the acute stuff. We've got to deal with the back stuff, with the spasm. Sometimes we get all sorts of extra little, party favors like Takotsubo's or neurogenic pulmonary edema or all sorts of other fun things to deal with. But I figured that I sort of break it down into like 5 steps, right? Seek and destroy is the first step. Whatever did this to you, get even. Don't get mad, get even. Take this person and get rid of it. Right? Deal with microcephaly if it's there. Oops. Do something with vasospasm. Because you've now seen a couple cases, and certainly in the discussions this morning, even more. Deal with these other medical complications, such as children struggling, and then somehow or the other get them home to, ideal, what are we seeking is baseline. This is not a case of the old joke, Doc, can I play the piano after this? Yeah, well, that's great, because I couldn't do it before. You've already heard some of the discussions also, the early versus delayed surgery. There's less chance to obviously, if the aneurysm is secured and obliterated, you can't bleed again, right? But there's been some question, is that necessarily a higher incidence of vasospasm? Well, that's probably not so true as long as you don't mess up the artery during the time when the risk is high. So those coming from the cooperative setting on the time of aneurysm surgery. I am not going to get into this except just to sort of flash this in front and be aware when somebody says, well, why did that guy get clipped? Why did this one get coiled? And whatever. And weighing the Detroit Medical Center to receive it, it's over 90% are getting coiled. Whereas coiling was reserved for those that were unclippable, now clipping is reserved pretty much for those that are uncoilable, except for young women. And this comes out of their chance. See? And you've heard much of it too. it was hard to argue, you know, and in the long term now, more than 10-year follow-up will occur. On some patients is the hope that, you know, we may get even more information that's useful. But, you know, there was a difference, those who got hurt from putting cord. It's probably anesthesias. Those are, you know, that's a vasospasm B. It always looks like a bunch of, you know, weenies on a string. That's what I figured. So, you know, so that very much now dealing with the issue of vasospasm, you know, as I said, the bottom line to think of is think of it the threes, as I said, you know, 2 and 3 are going to have some spasm. 1 and 3 are going to have symptoms. 1/3 of those, just work out, just have to kind of remember 13%'s got 3 in it, you know, are going to get hurt permanently or irrevocably or finally. You're 3 times more likely to die, you're 3 times less likely to have a good outcome. And it occurs between 3 days and 3 weeks. It's all 3s. Evil number 3. Current management right now is the so-called Triple H therapy issue. So you can just come back a little bit with this. You know, the bottom line is that hemodilution has never been shown to do anything of value. We thought if you thin the blood out, it would flow more easily through tight vessels. The bottom line was that might have made some difference for people whose hematocrits were over 45%. I don't know, you know, I'm so jaded, you know, from coming from New City Hospital for so long, you know, I think that normal hematocrits are sitting somewhere, you know, I'm pretty happy in the 30s.
Yeah, we never
Even
see
30
40s. At this stage, they're already diluted.
Yeah. So the bottom line is that that's probably, and nobody's ever been able to show a change. Hypervolemia, hyper to me is abnormal, so that's probably not it. I'd like to consider it as high euvolemia. If they're hypovolemic, that means you've got congestion. So the real thing, and then in independent analyses that have been, journal was in recently, looked at these 3 components, and the bottom line was that hypertension was the only thing that mattered. I like to think of it as hyperdynamic therapy. Sometimes you got to squeeze the heart a little bit. Sometimes you got to squeeze the vessel. But remember, before you step on the gas, always fill up the tank. And that's the fluid issue. I keep it simple. Neuroradiological intervention. Yeah, you say the idea was not to do it, or as little as possible.
Try everything.
I'm a believer in angioplasty. Definitely, you know, certainly. I guess it's the culture I grew up in, and I'm one of those investigators that you referred to this morning from the BPAP study. So, you know, not all great ideas work out. So, just ask my first girlfriend. She thought it was a good idea. At the time. Nimodipine has become standard of care. Right? Standard of care means what are you expected to do in your own, field, in your own neighborhood, in the national. We actually have an FDA-approved drug here. I'm going to get to the issue of magnesium and statins because we're interested in that. The goal here is vasospasm is one thing. Right? The issue is what we want to prevent is stroke. Right? It's permanent ischemic damage. Now, the high-purity calcium channel blockers have 2 studies that are pretty much shown. Now, our own study clearly showed, as was brought up this morning, that in a laboratory, if you take a piece of, you take a quadruped, or you take a piece of vessel, nimodipine is beautiful to stop it from having spasms or relaxing. And I like to think of it a little bit more, I like to call it the Christopher Columbus effect. You all have heard of some guy named Columbus. So Columbus set off looking for India. He didn't get there. But I would say that his benefactors, his sponsors, were not unhappy with what they came up with. Right? So our study actually should be decried, right? We all get bent out of shape. We hate it when we see negative studies. And the answer is that there was just as much spasm in the control group as in the treatment group. But they tolerated it better. Was this to neuroprotection? Was this luck of whatever reason? Fewer strokes, fewer dead people. It was everything we were after. So, excuse me, nicardipine, we had sort of the same thing, but the problem was to get the equivalent doses, we had to run it at nearly about 10 milligrams per hour in the average size bear. And the issue there was this was done in the days when we could sort of confuse water balance and fluid balance, and mannitol, dehydrate, oh, you don't want any brain swelling, Right? And what we got were a bunch of hypertensive people where that negated the benefit that came from it. So we could probably do it again, but I can't tell available data at the same time. There's the actual numbers, right? And if the evidence-based, Cochrane deities tell us to do it, well, we have no choice. Right? But nicely proven. It's nice to have it. Primary hypothesis wrong, but we were not unhappy with what Columbus found. Then there's the issue of magnesium, right? This is, been a drug of choice in the past for dealing with smooth muscle or irritable muscle disasters. And in particular, we can get them to relax and vasodilate. We figure this is great. If we take vessels in the lab, we can get this stuff to work. So, if we do that, and say we fill up people in a natural randomized trial, what do we find if we give them magnesium infusions? Well, we find, number one, that fewer of them actually develop vasospasm. Number two, we find out that fewer of them actually develop strokes. Number three, we find that if they get vasospasm, fewer of them get strokes. Just like that pneumonia stuff. So, sounds like maybe this is a good idea. Then there's the issue of ongoing stuff with statins, and we know we've had some rationale. We've got it certainly from the coronary artery literature that there's benefits beyond just lowering cholesterol, right? And in particular, we have independent studies from Duke and from Cambridge that have said that one drug or another, in some dose or another, look to be beneficial in phase 2 studies. So the STASH study is still ongoing right now, surgical drugs, so it's statin and aneurysmal subarachnoid hemorrhage. So stay tuned, right? We've been working on some stuff. I don't have time to show you there, plus I just don't have it all organized. Looking at, we had other things going on with our anticonvulsant and stuff with these patients. So we said, well, what happens if we take all these things at once and give them to patients? Because I'm still not sure any of those are magic bullets going to make a single difference. And now, like the people in the MASH study, magnesium, and they're not allowed to get statins, everybody's standardized. In the STASH study, magnesium infusion, so you figure, again, this comes back to the kind of bullets to try to do like shotguns. Right? Not often you get three phase 2B studies that agree with each other. There's another piece of this.
So with magnesium is a goal to get them in normal range, or do you?
Well, that's a good question. What about it? Is it just so?
Is more better?
The goals, if you look sort of in the traumatic brain injury trials, the goal achieved had nothing to do. And in fact, my first paper I was unable to ever get published as a fellow looked at magnesium concentrations in brain trauma patients. And what I got was a great big cloud between outcome and concentration. And it was amazing trying to show, well, see, it makes no difference. Wasted a long time writing it, never got it published anywhere. So that was about it. What's everybody doing on time? Is everybody else enough of this as well? You're allowed to speak up. All right.
Nobody
So,
wants to go first.
Oops, that was not what I wanted to do. That was the bad thing. So What about the other thing that really struck me about this is the fact that this woman gets so dehydrated. And in fact, I think that's what does in your other one here. So if you look at patients, just observation, what happens when you go back to these data, these times when, so this is published in the mid-'80s, and this is the time that, was that, full steam ahead, more mannitol, no fluid restriction, whatever, is you found a couple things. Is you found, number one, if you got patients who were, expected about 1 in 5 died, or ended up with infarction, if they were eunatremic and not dehydrated. And about 33% of those who were hyponatremic but not dehydrated did okay. But 81% wound up with strokes if they were hyponatremic and fluid restricted. So hypovolemia was really, seemed to be a bad actor as a percentage of those getting hurt. And there are lots of reasons, so I have to hazard a guess here because I didn't give any lab values, what happened to this woman. So she comes in normal and she runs into trouble and it seems like she starts peeing a lot and getting dehydrated about 3 or 4 days in. So my guess is she has some reason to be losing salt, because I think it's written somewhere in the medical Bible, whither goeth salt, there goeth water. And so a lot of this goes back, you don't read this stuff, huh? And a lot of the stuff
We
goes
had
back.
someone here with the Bible, so we all turned around and looked at.
Oh, really?
Yeah,
The medical
she
Bible?
reads from the same Bible,
Okay.
not salt and water,
Spend a lot.
Yeah.
Right? So it's found, a bunch of these patients have hyponatremic, and blood volumes were low, and, we had, certainly these people discovered over time past that were, you can tell I like the medical history of this, this goes under the trust no one, just because we got to this somewhere that somebody made a mistake before, right? And they negative sodium balance, they got dehydrated, these patients, and there was nothing changing about their ability to try and hold on to salt. So, another thing that was found is that, you needed a lot of volume to put into these patients observationally to keep them euvolemic, right? So, so-called normovolemic therapy versus hypervolemic, looked at those who got somewhere between 1.5 and 2 liters a day of crystalloid. Of course, I'd say that's still pretty hypovolemic. And this probably is from the way it was done in the time, in the early